I'm just going to talk about the normal labor, how the baby moves down into the pelvis until it's born. So I've got an imaginary baby here. And what we have is, what we need first is obviously the baby needs to fit into the pelvis. So if the baby gets into the pelvis, it can go in any position. It doesn't really matter. And with good contractions and also with the right size head of the baby being able to go in, the baby is pushed down by contractions. And as the progress happens, the baby needs to be moving down into the pelvis. And it then rotates when the baby's, when the cervix is fully dilated. And it then pushes down with more contractions. And when the baby is in this position, hopefully the woman is fully dilated. So there is no cervix being felt when the midwife does an examination. And the baby then starts coming out this way when the woman is pushing. And when the baby is fully out, the baby rotates into this position to allow the shoulders to be delivered. And the midwife then delivers the anterior shoulder, the first shoulder presenting, and then the posterior shoulder is delivered. And then the baby is delivered. So in a case of obstructed labor, if a baby remains in this position, as we talked before, that the baby needs to rotate around into this position because they are smaller diameters to deal with and coming out of the outlet of the pelvis. And also the baby's head needs to be flexed so that these diameters are the ones that are coming out first. So if a baby remains in this position throughout the contractions, then it's going to be difficult for it to come out. So labor can get obstructed. Although sometimes, depending on the size of the baby can be born in this position and this bit comes out first and then it rotates in the same way. If the baby remains in the OP position, which is back to back, and does not rotate, because the diameters that need to come out are wider, it might be difficult for the baby to come out this way. So the baby will remain probably in this position, and we can call that obstructed labor because it's not going to move further down because it's stuck in that position. But saying that, sometimes babies can actually rotate, or if it's a small baby, they can be delivered this way because the baby, the diameters can be dealt with that way. The other problem is if we have a really big head in a situation where it could be hydrocephalus, this baby is going to be finding it very difficult to negotiate its way down into the pelvis. So baby probably could be stuck in this position a lot earlier. If we have a baby that is, as I said earlier, if the head needs to be flexed, so that means it's looking down this way. So if a baby is deflexed, then the big diameters are going to come out first, and that's going to be difficult to negotiate a way out of the outlet. So it could get stuck, and it could get stuck when it has gone further down because it is remaining deflexed. If we have a situation where somebody has pelvic abnormalities because the room in the pelvis is just not adequate, then again, the baby is going to find it difficult to negotiate its way out of the pelvis and to do the rotation. And we also might have a situation where the baby is just generally bigger than the mother's pelvis. So it could get stuck in any particular, so it won't be an issue of position, it will be a situation of the baby is just too big for the mother's pelvis, so it doesn't go further down. And we can be in a situation where the face is presenting rather than the head. So we have a face coming out this way. So again, you can see that the diameters are too big to come out of the pelvis. So baby can be stuck in that particular position. Sometimes the shoulders are presenting. So you have the shoulder presenting like that. again, that's going to make it difficult for the head to come down. So labor could get stuck. So it's really important to be able to diagnose that early on and apply appropriate management. So it will be a situation of transferring to a hospital. If it's in a hospital, then that baby might need to be delivered by cesarean section. We can be in a situation where the baby has actually made all the necessary progress and there are no issues with the position and presentation. The baby is made its way all the way down and we get to the perineum. And a woman who's had FGM, there's going to be a restricted room at the vaginal introitus. So a woman who's had FGM type 3 in particular is going to struggle to deliver this baby, so will need an episiotomy. That's why it is advisable for women who've had FGM to have the defibrillation procedure, which means opening up the area that has been sewn together to give them more room to deliver the baby. This also can be done during the delivery of the baby, where we can open up the area that has been restricted and be able to deliver the baby. But if that doesn't happen, that can cause obstructed labor and the baby could be distressed as it's being delivered. And if that is not corrected. So ideally, it's best to correct it before the time of delivery. It's important to be aware if a woman has had any pelvic injury, because that might alter the space that's available for the baby to be able to make the necessary maneuvers to be delivered normally. It should be recorded in antenatal history and to anticipate potential problems. Obstructed labor can cause soft tissue damage because the head is constantly pressed against the soft tissue between the bone and the head. And that can cause tissue death, and that can result in a fistula. That can impair the bladder. It could be the bladder or it could be the bowel. So it's really important that we identify obstructed labor as early as possible. For some women, they are laboring for days. And with that constant pressure on the soft tissues, that will cause tissue death around that the areas that there is pressure on. The other complications from obstructed labor are infection, because probably the ruptured membranes have been ruptured for a long time, and then infection travels all the way up. And also in primates who are first-time mothers, the uterus stops to contract when it's been contracting for a long time, and that's why they are at a greater risk of having fistulas compared to mothers who've had babies before. Mothers who've had babies before are at risk of having uterine rupture because for some reason the uterus continues to contract even though the labor is obstructed. And then it continues to contract until the lower segment becomes very thin, and then there's the risk of uterine rupture.